afternoon. It's just past 12 o'clock now, and Dr. Peng will be along in just a minute. He is busily seeing patients, but I understand we're going to have some questions and answers. At least I hope I have some answers, but we'll have to wait and see how it goes. I have one question that came in, and that was a patient with a question about tinnitus. And you know, this is something that is very common. It's a symptom, by the way. It's not a disease. So it can be caused by any number of things, such as a hearing loss. In fact, about 80% of patients with hearing loss will have tinnitus. It can be constant or it can be intermittent. But the tinnitus is not generated in the ear. That's something that we discovered many years ago. But we know that anything that influences the brain, because that's where the tinnitus is generated, can make the tinnitus worse. And so if a patient has anxiety or pain, back pain, neck pain, anything like that could cause the patient to have tinnitus. What we look for is an underlying cause. For example, it may just be wax in the ear. Take the wax out, the patient can hear better and their tinnitus goes away. Or they could have a disease of the eardrum or middle ear bone. And again, if this is corrected and the hearing loss is corrected, many times the tinnitus goes away. Excuse me. The more common type, of course, is associated with a nerve loss. If the patient has a hearing loss, we can recommend hearing aids. We can't do surgery on patients with nerve-type hearing loss. I hope that answers your question. I mean, we could go on for a couple hours on tinnitus. Other questions?
One question came in, how do I know if I am a candidate for a cochlear implant?
That's a good question, is how does this individual know that she or he is a candidate for a cochlear implant? Cochlear implants are basically for people who have severely profound hearing loss. As a general rule, if you cannot hear or understand speech, then with a hearing aid, with everything that you can do, then you certainly need to be evaluated for a possible cochlear implant. And we look at certain things such as if the patient, for example, can only understand 30% of the words, even with their hearing aids, then they're definitely a candidate for a cochlear implant. Generally, the hearing has to be worse than about 70 decibels, and the normal is 25, so anything below 25 is normal. So 70 decibels or more is really quite a significant hearing loss, and these patients probably would benefit from a cochlear implant.
Another question is, how do I know if sound is damaging my hearing?
Another good question. How does this individual know whether noise, loud noise, is damaging the hearing nerve? The little hair cells within the cochlea, and the cochlea is that little spiral shell structure which is filled with fluid and has normally 15,000 hair cells. And they're arranged around the cochlea according to their frequency response. And if they're exposed to excessive noise, then they can be damaged. And as a general rule, if you have to shout to be heard over the loud noise, then it's too loud. So this can be the case in factories, people running various heavy machinery, jackhammers, things like that will potentially, over time, cause a hearing loss, typically in the higher frequencies. But as time goes on, this can begin to affect the speech frequencies. So anyone who's around excessive noise, loud noise, by the way, such as a rock concert, one should wear ear protection, and earplugs or earmuffs work quite well.
After vestibular schwannoma excision and preserving the cochlear nerve, why do hearing decrease in the long run?
Well, that's a good question about whether people who have had an acoustic neuroma, that's a benign tumor which involves actually the vestibular nerve, not the cochlear nerve. And when the tumor is removed, we try to preserve the cochlear nerve and the facial nerve, by the way, because that's the nerve that moves the face. And these are all intimately involved with the tumor. So very careful surgical removal can preserve these nerves. I think the problem is would the hearing loss progress even though the tumor is gone? It's probably because of the limited blood supply to the inner ear, and so over time the ear just isn't getting enough nourishment and the hair cells begin to die off.
Any new technology or new techniques around acoustic neuroma removal?
Well, we're doing all kinds of interesting things like image guided. I think the bottom line, though, it's the surgeon who does a lot of these tumors and has a great deal of experience. And we use the operating microscope. We monitor the facial nerve because it's being overstimulated. That may mean that we're irritating the nerve too much. We also are able to some extent, monitor the hearing nerve, even though that's not as accurate and doesn't give us the full picture.
How does PPPD affect inner ear with balance, and what's the cause?
Say those initials again. I think they're quite right.
They wrote PPPD. Maybe it's not.
Yes, benign paroxysmal positional vertigo. So it's a V. Anyway, that's a condition that's related to little crystals, which are normally in the what's called the vestibule of the inner ear. And this is all, by the way, our balance is controlled by the inner ear. Of course, our eyes and our feet, everything contributes to maintaining our balance. Well, normally there's fluid inside these canals, and so every time we move or change position, the fluid will move back and forth. That will deflect a little sensor, which causes that nerve to go to the brain, go into a coordination area where everything is coordinated, and that's how we maintain our balance. Now, if these little crystals move into one of the balance canals where they're not supposed to be, so when a person lays down typically in bed, rolls over to one side, those little crystals will drift down, they will hit that sensor and cause it to overreact, and all these messages go to the brain saying we're spinning or we're turning, when it's really just due to the deflection of the little, what's called copula. It's benign, that's why we call it benign paroxysmal vertigo. Many times will go away on its own, but the treatment is really quite successful. It's called an Epley maneuver, and that's named after John Epley up in Portland, Oregon, who first described this. And everybody kind of weren't impressed with what he said. They didn't believe him, but as time has gone on, we have found that it is very effective. I would say that in my experience, about 80% of the patients have an Epley maneuver once, and that usually solves the problem. About 20% it either doesn't work or it may recur from time to time. And if the case it's recurring, then doing a repeated Epley will take care of the problem.
Okay, this person says that they have a problem with their left ear. In the presence of loud noise of jumbled frequencies, a loud clicking noise starts up in the left ear, which prevents them from understanding any speech. What could this be?
That's a good question. A clicking sound, when they're exposed to certain sounds, seems to interfere with their hearing. Well, first of all, clicking, there are two muscles within the middle ear. They're attached to the two of the three ear bones. There's the stapedius muscle attached to the stapes bone, and the tensor tympani, which is attached to the malleus. And these will contract with certain sounds, and so sometimes patients will start to notice a clicking sound either when they're exposed to noise, or it may just come on spontaneously. Again, many times that's self-limiting, goes away. very rarely will we actually go in and do a surgery. We'll cut the tendons to those little, to the bones. And the good thing about that is that that works very well. It's an outpatient procedure, and normally just done under local anesthesia. And there's very little risk to it. The only risk, I guess, if it didn't work. But in my experience, it does work. But it's very rare that we ever do that because most patients, it resolves over time.
Sometimes exposure to strong or cold wind makes my ears ache. Is this dangerous over time, like when skiing or riding with the windows down in a car?
Well, the question is whether cold air around the ears causes any damage. It does cause pain in some people. But no, it doesn't cause any damage other than it can be uncomfortable. Obviously what we can do is we can put little cotton balls, have them just use cotton balls to, when they're going to be out in that kind of wind, and that should solve the problem. Well, it looks like Dr. Peng has arrived.
Yes, I sure have.
Come on in. I think you have
Thanks.
to look this way.
Hello. Hey, Dr. Peng. Sorry about my tardiness.
I'm sure you're busy today.
As are you. Okay, I'll take off my mask also.
Yeah, I decided we
We're,
probably don't need it in this room, even though it's a small room, but we're all,
I got my second booster, so.
I got the whatever the most recent one was.
Mhm.
Did you have any reaction to it?
This about the same as the first couple. A little bit of a headache.
Yeah, I had kind of achy pain. It's the first time I've had any kind of reaction. Anyway, other than that, we're all fine here.
So we've just been talking about exposure to strong or cold wind and how that might affect your ears and if that's dangerous and over time, like skiing or riding with the windows down in a car.
Mm-hmm. And I know you already started answering this, but I don't think it's particularly damaging long term, with the exception that long-term exposure to water and wind, such as with surfing, can cause exostoses. And that doesn't damage the ear, but it does cause, again, those bony growths, which we call surfer's ear, in the ear canal, which, if it's severe enough, can cause a hearing loss. Fortunately, that hearing loss is typically not a nerve-type hearing loss. It's what we call a conductive, or like a mechanical hearing loss. But aside from that, usually exposure to wind in the car isn't damaging. I will say though that sometimes cars can be very loud, and sometimes trucks or vans and other types of transportation can be very loud. If it's uncomfortably loud, maybe earplugs might be a good idea, depending on the situation.
With the cold wind, I think just putting cotton in would be probably adequate.
Yeah, or an earplugger.
Well, yeah, except that you can't hear so well.
That's right.
Cotton doesn't block out the hearing so much. A little bit, but not much.
Okay, our next question is about persistent postural perceptual dizziness. Hope I'm saying that right. Have there been any new developments in the drug treatment?
I don't think there have been any major new developments in treatment of PPPD, or sometimes we call it 3PD. I think the mainstay of treatment would be, number one, I think vestibular therapy is extremely helpful, and I know that's not a drug, but that's very helpful if somebody hasn't tried it already. And then we look to certain types of medications, some of which we use for antidepressant medications also. So we're talking about what we call SSRIs, selective serotonin reuptake inhibitors, or SNRIs, one of which is Effexor or venlafaxine. Those are the medications that we typically use for patients with PPPD. I don't think that has changed much over the past few years. I think those are still very standard medications that some physicians will prescribe for this condition.
And explain what it is.
We used to call this condition chronic subjective dizziness, but it is a sensation of dizziness that can ebb and flow, but often patients feel like they have it all the time. So it doesn't strike them in discrete episodes like we might think of a Meniere's patient.
Mm-hmm.
And then so basically we're trying to treat the symptoms of dizziness, but also associated symptoms like brain fog and that sort of condition with these medications.
Do you find this happens more in the older patients?
I think it can happen in a variety. I think it can happen actually to a lot of middle-aged patients also. Similar to vestibular migraine. There is overlap between vestibular migraine and PPPD, and so those can definitely affect middle-aged patients too. Young patients, not so much. Definitely middle-aged and older are most common. I would say.
Can you explain what Meniere's disease is and how it is related to vertigo? This question is specifically asking if Meniere's disease and vertigo are something that occurs together, or is it a one or the other type of situation?
Or both.
Or both.
Go ahead.
Yeah. Meniere's disease is basically a set of symptoms. One is episodic vertigo. We'll get into that a little bit. Secondly is fluctuating hearing loss. Thirdly is pressure in the involved ear, like a fullness. And lastly can be tinnitus. So this is caused by a change in the fluids within the inner ear. And as the fluid builds up, it causes a sensation of pressure. The little membranes may rupture and cause a flow of fluid, causing the episode of vertigo, and the patient may develop a low frequency type of sensory neuro or hearing loss. And that also fluctuates. So basically it's all of those things together. They can occur once a week, and it can occur once a year. It's a very frustrating thing for the patients, and it's something that we do treat medically and sometimes surgically.
I think one of the points, it's almost a matter of semantics, that either physicians or patients or both will get confused about is vertigo. I think vertigo is the sensation of movement when none exists. So typically we like to ask patients, do you feel like the room is spinning? But sometimes patients will still have vertigo and say, actually, no, I don't feel like the room is spinning. I feel like I'm the one who's swaying. We still call that vertigo. And patients with Meniere's disease will have episodes of vertigo. Vertigo can also happen in other conditions. Sometimes when you have benign proximal positional vertigo, which is when the balance crystals are loose in your inner ear and you get dizzy when you lie down, that's also vertigo. And so all those are types of vertigo, and when patients have Meniere's disease, vertigo is one of the check boxes that we have to check off. If you don't have vertigo, officially we don't call it Meniere's disease. But it's not like you have to have only one or the other. No, rather all Meniere's patients, from that point of view, really do suffer from this sort of vertigo.
There is a what we call Cochlear eye drops, and that's when the patient has the same symptoms as far as full pressure, tinnitus, and fluctuating hearing loss without the vertigo.
Right.
So,
Absolutely.
That's so that it's all a continuation of the same thing, depending on what's involved.
Can you explain why those with hearing loss experience pain from loud sounds, as with recruitment /
Hyperacusis.
So this person is saying people don't understand why I can't hear them yet complain about loud noise.
Well, I think there are a couple of angles about that. One is, I think there's something physiologic, something protective about our own body, where when we have a hearing loss, over time our bodies have evolved to almost amplify on its own certain sounds. And I think that's probably comes from the hair cells, and I think that's something that's probably sort of come through evolution. And sometimes when patients with hearing loss, that effect is present not only for the soft sounds but also for the large sounds, and it is when really loud sounds come at the ear in those patients that people really feel this discomfort. And so yes, we do call it recruitment, and it can cause hyperacusis or painful or unpleasant.
Very
feeling.
uncomfortable.
Yeah.
Yeah, it could be miserable. I think part of it could be synaptic too. This is something recently we discovered, that the synapse is the junction between the hair cells and the nerve itself. If we begin to lose those, we think we begin to lose, in some cases, the control that would dampen the sound normally, and the sound just becomes overwhelming.
Right. And it is difficult for patients without hearing loss to understand that. There are certain patients with hearing loss where soft sounds are hard to hear and loud sounds are uncomfortable, and sadly their dynamic range, as we would put it, is much more compressed, where comfortable sounds that they're actually able to understand is a lot smaller of a range. So.
Yeah, I like to say this is when someone barely hears something, is someone of normal hearing, and that they can tolerate sounds this loud. Now, a person who has a hearing loss, first of all, their threshold is way up here, and yet their threshold for discomfort actually gets a little bit more narrow. So they have a narrow dynamic range.
Yes.
So this person is looking at a patent using Busperone. I don't quite know what that drug is, but it's a drug for PPPD, and is wondering if it could be an alternative to SSRIs.
I haven't prescribed it personally. Usually I use a venlafaxine or an SSRI for it. I think that's something indeed to be investigated.
So which medicine was that?
I think it's one of the newer antidepressants on the market, and I don't recall the exact mechanism of action either. So I don't have any personal experience with it myself, but certainly if it's being tried, I think we'd all want to know if it's going to help.
Great. Okay. The next person wants to know what causes tinnitus.
Right, we got into that a little bit earlier before Dr. Peng arrived, and I was explaining that it's central, it's coming from the brain. It can be caused by presence of hearing loss. 80% of patients with hearing loss have it. And the hearing loss can be due to wax impaction or nerve-type hearing loss. Go ahead.
And I think, it is coming from the brain. I think there are probably positive feedback loops in the brain, positive feedback meaning in a bad way, where these neural circuits are just getting amplified, and there's something about patients with hearing loss that causes these circuits to keep conducting and basically produce the perception of hearing a sound when none actually exists. Ultimately, I don't think we really understand what causes tinnitus. We don't know why it's there. It doesn't seem particularly protective, unlike some other reactions, like we talked about how recruitment is sort of the body trying to amplify sounds when it knows it can't hear that well. But I don't know why we have tinnitus, and
No, it's very frustrating. It is generated near what's called the limbic system, and that's where our emotions are. So that's why I mentioned earlier that anything that adversely affects a person can also cause it, such as a injury, or pain, or emotional upsets, or fatigue coming in, getting home from work after a long bad day. Your ears may ring.
or anxiety.
The good news too is that 95% of patients who have tinnitus eventually or do learn to just ignore it. It's like, if there's a sound in your room, your refrigerator or your air conditioner makes a noise, we don't hear it because we're not concentrating on it. And that's what most patients will learn to do. It's there, they don't listen to it, and it's fine. But there are about 5% of my patients that are very disturbed by it, in which case it becomes a very frustrating problem. We have to try different modalities of treatment.
This person wants to know if you can, apologize for butchering this, but if you can get more than one gentamicin shot? Did I say that right?
Yeah.
Okay.
Well, first of all, we're talking about intratympanic gentamicin. I think that's what we'd be talking about.
Yeah.
Gentamicin is toxic to the inner ear. And so for this is patients who have severe vertigo, we may try giving them gentamicin to try to calm down or get rid of some of the balance function in that ear. And it can be effective, and we will give any number of injections. Normally, I like to start with one, see how they do. If they still have some vertigo, then give another injection. I would say 3 would probably be as much as I would want to go, because it does run the risk of hearing loss.
I agree with that.
Do you guys have any questions from your patients that you think would be interesting to share?
3,000 pages a day.
I think one thing that patients often ask about is regarding cochlear implants and when is the right time for a cochlear implant. I think that can be a difficult decision for patients with severe to profound hearing loss. But I think what's really helpful from our point of view is when the audiologists at our clinic will do very specialized testing. And so we basically see how well or how poorly somebody performs in the presence of background noise. And that's not a test that's easily performed. So that's not something that a patient can necessarily pick up on. So we use that as almost one of our criteria for deciding if somebody needs an implant. So sometimes it can be difficult, for a patient to arrive at, is it the right time for me to get an implant now? But I think just from a very general perspective, if somebody is having significant trouble understanding spoken conversation, despite the use of hearing aids, it's something that should be considered and explored.
Okay, we've got a question here that says, I don't get ear infections, even as a child, except after scuba diving. I've been told I have narrow, twisty ear canals. Is there anything you recommend that could help prevent ear infections after diving?
What twisty ear canals are. And I'm not sure what they mean by infection. You know, could it be what's called swimmer's ear, and that is with getting water in the ear, a person can't have a reaction and get an infection, either a fungal infection or bacterial, or may just get itching ears. But what we would recommend, if it is in the ear canal itself, would be to get eardrops and just put the eardrops in afterwards. I guess some people use a little vinegar or alcohol after swimming in order to dry up the ear, as long as the eardrum is intact, by the way.
Mm-hmm.
But of course, we don't recommend people to scuba dive if they have a hole in the eardrum either.
Right, no.
Which I'm questioning that, actually.
Yeah.
Because if you wear an earplug, and you can still Valsalva.
Yeah, well, if you have a hole and somehow you can keep the water from going in, technically the pressure is much more readily equalized.
Yeah, you use bending, okay. Anyway, that's an aside.
But I think for that question in particular, it'd be important to know, as you said, make sure that the person asks their ENT, are we talking about swimmer's ear, which is an outer ear infection? When we say outer ear infection, we think of this part. No, but outer ear infection actually refers to the ear canals. Is it an outer ear infection? Or is it a middle ear infection underneath the eardrum?
Mm.
And if the patient gets middle ear infections or some issue with the middle ears, then we start thinking, oh, is it because your eustachian tubes have a problem? And so it's really important to make that distinction. And certainly the physician, I'm sure, knows. It's just sometimes things get lost in translation when we're trying to explain what exactly is happening. So I think it's important to figure that out, and then we can figure out, is it a mechanical issue of ear hygiene, as Dr. House was saying, or is it a eustachian tube problem relating to inadequate clearing of the ears when scuba diving?
What are some treatment options for vertigo that comes and goes?
Again, we have to figure out what it is and why it come and go. If we're talking about mid-years, as I mentioned earlier, there are medical treatments that we do, and if medical treatment doesn't work, there are surgical procedures. If it's due to benign positional vertigo, which we talked about, BPPV, then doing the Epley maneuver will usually help that. There is also a recurrent vestibular neuropathy, where people have like it's a viral infection on the balance nerve that every once in a while gets activated, like if it were a herpes type of problem. And again, using antivirals and steroids many times will help that. So there's no one single cure for any of this.
It could be vestibular migraine too, and there are other treatments.
Oh, that's
for
right.
that.
Sorry, I forgot about that. Very important part of it.
And medications or vestibular physical therapy helps a lot of different types of dizziness too. So even if we can't pin down the diagnosis at the first visit, often I'll have patients participate in vestibular physical therapy, and they can report back to me how it went and if it's helping their symptoms, and that can be very beneficial to certain patients also.
What is the most important research being done to reverse hearing loss and to better treat or cure Meniere's disease?
Well, that's a double question.
I don't know if we know how to reverse hearing loss. I think that would be one of...
Well, yeah, there is. I mean, if you have a patient, again, there's no one thing. The question is, what do you do, or how do you reverse a hearing loss? If a patient has a sudden hearing loss, then we'll generally treat them with steroids. And 50-60% of those will get improvement. Sometimes we'll get dramatic results. Occasionally we'll inject the steroids directly into the ear, doing what's called intratympanic, and that'll help to reverse it. So there's those treatments. And now if it's just a matter of the progressive hearing loss due to aging or due to loud noise exposure, no, there's nothing we've learned to reverse that. We can't yet regenerate the little hair cells, but we're working on it.
In terms of Meniere's disease, I think there are more and more medications on the horizon. There's some clinical trials that are available, and I think those are fairly promising. in terms of addressing, I think, the most recalcitrant of cases where we try our usual remedies and things don't improve as we would have hoped.
Why do SSRIs work for PPPD even in people who don't have anxiety?
I think it goes back to the thought that, to a certain degree, PPPD is our neurons not really being coordinated or talking to each other correctly. I think that's how SSRIs may work in this condition. Now, some may argue even if anxiety is undiagnosed, maybe there's a component of it there. Maybe somebody has anxiety that doesn't tick the regular check boxes of this would be considered generalized anxiety disorder. But I think it helps because it works on neurons, in short.
What is the most... Oh, sorry. Can hyperbarics be useful in treating hearing problems other than SSNHL?
What is that?
Hyperbaric oxygen or
What
hyperbaric
is
therapy,
that?
yeah.
What's the
Sudden sensorineural hearing loss.
Oh, sudden.
Well,
Some people have used it.
Yeah, I think it's the indications are for sudden sensorineural hearing loss, and we do not routinely prescribe it for any other type of ear condition.
Yeah, I have not found it to be helpful in my patients. I've not sent patients, but a lot of patients have gone over across town where they do it and have not had a good result, unfortunately.
Yeah, and sometimes patients are getting other therapies too, so it becomes really difficult to parse out what is.
Yeah, they're on steroids and they're doing hyperbaric oxygen and
But the short answer is no. That is the one condition that we prescribe it for in the field of otology and neurotology.
Is there anything I can do as a young adult to protect my hearing as I age?
The most important is avoid loud noises. Concerts are fun. I like going to concerts. Wear earplugs. Wear hearing protection. They can be as simple as foam earplugs you buy from the drugstore. They can be earplugs you buy online that are musicians' earplugs, which have sort of a flatter frequency curve so that the high frequencies are still maintained, so music still sounds really good, just at a lower volume. They can be as fancy as you getting custom molded earplugs with different types of filters or inserts to change how much they're blocking out sound. And one would get that typically from an audiologist. But the most important thing is to wear earplugs when you're around loud noises.
Yeah, I'd say too, that protecting your ear around loud noises, as he said, is very important. Let's get into shooting, because that's an area I think where a lot of patients will lose hearing due to they go to the gun range without protection, or they hunt without ear protection, or of course in the military, it's probably the most major disability we see is patients having significant hearing loss after combat. So, and again, many times it's not possible to wear ear protection in those situations.
Right.
You know, I had a lot of police officers and sheriffs that I take care of, and I was a reserve deputy, so I'm very familiar with what they do. And they wear their ear protection when they're on the shooting range. Now, they didn't used to many, many years ago, but now they all have to wear earmuffs when they're shooting. But again, the problem is when you're in the field and there's a shooting, you know, they're having to use their guns, then they don't have time to put their ear protection on.
Right. And it's almost, I think the military has a slight advantage in that regard, because there are definitely headsets that are worn that partially attenuate sounds coming from the outside, and also facility communications. Those exist. Various specialized earplugs exist in the military setting. If anybody watching is an avid shooter, when you go to an indoor range, you should absolutely consider plugs and earmuffs, not just one or the other. Outdoor ranges are a lot less loud than indoor ranges. If you're shooting a long gun, or worse yet, if somebody's in the bay next to you shooting a long gun, make sure you wear double hearing protection, because unfortunately it only takes maybe 1 or 2 episodes of exposure, even just 1 or 2 shots, and if it is at levels that damage your ears, that can cause significant issues long term.
Well, that's interesting. You know, President Reagan was one of my patients, and he lost his hearing in the right ear because an actor, when he was on the set, they were supposed to come stand right next to each other, but instead the actor was right back here when he fired his gun, and it just knocked his hearing down, and he had a permanent hearing loss in that ear.
Right.
Can you quickly explain the difference between like the foam earplugs you can get at the drugstore and the really nice custom earplugs you can get from an audiologist?
All earplugs will have like a noise reduction rating on them, and then so that generally gives you an idea of how many decibels it cuts down on. Foam earplugs, when you look at the frequencies they attenuate, the high frequencies are significantly attenuated, so things sound a lot more muffled and a lot less crisp. If you get musicians' earplugs, the frequency response is flat, so it cuts down all the frequencies by roughly the same amount. It's not perfectly flat; it's flatter, so the high frequencies are still preserved, so that music might sound like the music that we're used to listening to, just at a lower volume. That's the primary difference.
Well, as a general rule, the foam earplugs will provide about 28 decibels of attenuation, and earmuffs would be about 33, just to give you an idea. And remember, noise levels above 90 decibels can be potentially dangerous. So if you're going to a rock concert with 120 decibel, wearing foam earplugs help.
Mm-hmm.
But if it's too loud or too length of a time, it can be a problem.
Right.
When patients ask me what's the best earplug, it's whatever you're going to wear.
Right. I agree.
As long as it's in the ears.
Can anything be done to help reduce ear pain on airplanes, especially for young children when descending in elevation?
I think a few things can be tried. There are airplanes earplugs, and if the ear canals are large enough to accommodate those earplugs, they can help. They're earplugs that basically equalize pressure very slowly. They have a little valve that helps equalize the pressure slowly, so that when there are wide pressure swings, such as when we're ascending or particularly when we're descending, it can be a lot less painful.
And those are developed at the House Ear Clinic,
Right.
House Institute,
Right.
by the way.
Yeah.
Which you knew that already.
And then
I had to get a plug in.
you can buy those at airports. I know lots of airports sell them, or you can just get them in preparation for a trip. And in addition, you can use medications like decongestants such as Afrin and like pediatric strength, or Sudafed pediatric strength, and those are both basically medications that can help decongest the nose. In doing so, decongest the eustachian tube and make it easier for the eustachian tube to equalize pressure when there are pressure swings, such as when we're going up or down in a plane.
And the other would recommend would be, like, if it's an infant or baby, if they would feed the baby as they're coming down, because the problem comes from descent. So as the plane begins to start to descend, if the little baby can get a bottle to begin to swallow, because when you swallow, your palate pulls up and that opens the eustachian tube. And that's why most people will say, yeah, when they swallow or yawn, they hear their ears pop.
Right. Or chewing gum, which is another.
Well, chewing gum was just
if the kid is old enough to.
I was going to think of it. Yeah, but it's just the idea to get people to swallow.
Persistent postural perceptual dizziness, PPPD. What causes the feeling of floating when sleeping or swaying in bed?
You'll have to answer that one. I have no idea.
I don't know if we know what causes it. It's similar to the syndrome that they call MDDS, or mal-de-debarbement syndrome, when patients feel like they are moving even when they're on solid ground, and that's usually triggered by, I think most typically a boat ride or sometimes being on a plane. I don't think we know. Sometimes colloquially people will call it sea legs, because there's some thought that if there is constant muscle tone to our legs in our body, then we'll have better posture and better stability at sea. When that happens on land, people interpret it as a constant feeling of motion. But I don't know if we know why that happens in PPPD and also MDDS. I don't know if it boils down to the nerves and the neurons. I don't think we have a convincing explanation for what exactly is the root cause.
And it's not unusual people get off of a boat and they feel that they're rocking, and that usually lasts for several hours and maybe a day. But we have an occasional patient who it continues.
Mm-hmm. Right.
I don't know if you know Dr. Sheehy's prescription was
no.
Send him back on a boat. Because when you're on the boat, it's the boat's rocking, that's fine. But when you got on the ground and the ground's rocking, that's different.
Yeah. I've had one patient tell me that it got better after they took another flight and came back down, and that cured it. So
there you go, same idea.
But we don't know. We don't know what the pathophysiology, as we say, is. What fundamentally causes it.
Can you explain the different treatment options for an acoustic neuroma?
Yeah. So I think the most simple option first is observation, and we call it observation, but really what we're doing is we're getting another scan, typically an MRI scan, in 6 to 12 months after the initial diagnosis, and usually every 6 months or more likely 12 months after that. There's surgery. So in certain cases where the tumor is extremely large, then surgery will be
or
recommended.
is actively growing.
Mm-hmm.
So
Exactly.
then
Even
we
if
have-
it's small and growing,
Then
that could be
then we have to make a decision.
right. So there's surgery, and that can be performed a variety of ways. And finally, there's radiation therapy. I think most physicians who perform radiation now in the United States are using stereotactic radiation. That includes technologies like CyberKnife and Gamma Knife, but there are also other technologies available. Sometimes regular radiation therapy, fractionated radiation therapy, can also be used, and that can stop the growth of a tumor. But it's basically those three approaches. Either we watch it, wait, or we do surgery to take it out, or we do some sort of radiation therapy to stop it from growing.
Yeah, because the tumors are first of all benign. They're talking about acoustic neuromas being it's a benign tumor, so it isn't like cancer that we have to be very aggressive with.
Mm-hmm.
And if it's relatively small and not causing like pressure on the brain, then yeah, we can just wait 6 months, check it again,
Mm-hmm.
and we have the ability to do that with the MRI, which we didn't have when I first started
Mm-hmm.
many years ago. We did not have a way of actually following them. So now we can actually see if there's just a 1 or 2 millimeter change in 6 months.
Right.
Any more questions from today, Dr. Peng?
That I can think of right now. I'm sure. I think some people want to know how to prevent outer ear infections. I know we sort of touched on this when we were talking about the scuba diving question. But I think for somebody who is prone to getting lots of outer ear infections, like ear canal being wet and having a lot of pus, the most important thing is to keep your ear canal dry. So sometimes patients will come see us too, and they've only had one outer ear infection, but it's super important that during the healing process, as well as perhaps afterwards, that you keep your ear canal as dry as possible. That can mean using an earplug when you shower, using a cotton ball with Vaseline smeared on the outside of it when you shower. Sometimes people need to dry their ear canals with a hair dryer or even an ear dryer device that you can buy online. And that can be all that's needed to fix that ear infection as well as prevent further ear infections.
Yeah, when they're recurrent, we have swimmers.
Mm-hmm.
That's why I call them swimmers here. Maybe a competitive swimmer, they can't stay out of the water
Mm-hmm.
or give it up. And I'm like me because I love the water. So people can wear earplugs when they swim.
Mm-hmm.
And as I mentioned earlier, we can always use eardrops after you swim.
Mm-hmm.
So it's definitely preventable. When you have an acute infection, the ear canal swells, there's severe pain and all, then obviously you do have to keep the patient out of the water at that
Mm-hmm.
point. Well, I guess we're done here. No more questions?
I guess we are. I guess we can call it a stream.
That's a wrap. Is that what you say, Randy?
That is what I say.
Yeah, if there are any other questions, feel free to reach out to our team. We have a bunch of social media outlets. We'd love to see you on another one of these. And, we can cover any topic. If you have a particular topic you want to hear about, let us know. We always brainstorm internally about what we think people would like to hear about. But if you have any suggestions for us, we'd be happy to hear those too.
And you look at our website of the Institute and the clinic,